of participants that we have, your audio will be muted throughout the call. But you, at any time, you can submit questions at any point in the presentation via the Q&A feature, or you can also just type them in the chat box in the webinar console. The entire webinar is being recorded. It'll be available on the ARP website if you'd like to reference it again. I will paste that in the chat once Dr. Sanders gets started. And then there'll also be a short evaluation survey at the end of the webinar. And we really invite you and encourage you to provide feedback on the webinar and the suggestions for future topics, speakers for future webinars. But in the interest of time, let's get started. I just want to first acknowledge the Health Resources and Services Administration as a funding source for ARP. So the ARP project is supported by the Health Resources and Services Administration of the U.S. Department of Health and Human Services under the Autism Intervention Research Network on Physical Health grant. So this information and/or conclusions are those of the authors and should not be construed as the official position of or policy of, nor should any endorsements be inferred by HRSA, HHS, or the U.S. government. So with that being said, I'm going to pass it off to Dr. Sanders to start with the presentation.
Great. Well, thank you so much. I'm Jessie Solomon Sanders. I got the AARP grant, which I'm so grateful for, to support this work about 3 years ago. And so I did a qualitative study and a quantitative study about adult neurodevelopmental care and new advancements in that field clinically. And so I am here to share a little bit about what we learned. Please feel free to jump in with questions with the chat. And Ben, if you see something come through that I don't see, please interrupt me because I want this to be useful for AIRP or future scholars or people thinking about other grants and how I develop that. So that's the goal. So I'm going to go through just quickly because we all know there's a lot of need out there with this population. I'm going to go through the background of the need, and then I'm going to talk about the methods we used qualitatively to evaluate what do adults with neurodevelopmental disorders, primarily autism spectrum disorder, value out of adult neurodevelopmental care and their caregivers as well. We'll talk about the results that we had, and then also I'll give you a quick rundown. Since my AIRP project was twofold, qualitative and quantitative, I'll reveal some of the quantitative data that we found too, and how to start an adult neurodevelopmental clinic and who comes and what we found. And then we'll talk about conclusions and next steps and other projects on the horizon. And I will welcome your questions, hope to leave lots of time for brainstorming or collaborations, things like that. So we all know that increasing numbers of children with neurodevelopmental disorders, including autism spectrum disorder, are becoming adults each year. And we know that developmental care is important, and there are lots of studies that have shown that getting specialty neurodevelopmental care improves health outcomes, both with health and in value of healthcare. However, most neurodevelopmental specialists practice in pediatric settings, and there is not a standard of care for adult neurodevelopmental specialty care, even though we have a lot of data and studies saying that it is important in general for individuals with neurodevelopmental disorders to get specialty neurodevelopmental care. We also know that transition to adulthood is difficult. So adults with neurodevelopmental disorders have more negative experiences with healthcare and experience disparities in being able to access healthcare compared to the general population. This includes preventative primary care, oral health care, let alone specialty or mental health care. And there's lots of wonderful colleagues, some probably on this call, that have done great work in this area defining these disparities of transition planning and of healthcare access in adulthood. So while we have fabulous childhood and pediatric neurodevelopmental clinics and standards, there are not yet standards for what is considered high quality care. And that is what motivated me to apply for this AIRP grant, was to begin to define what makes up high quality care for adults with neurodevelopmental disorders. And I wanted to first understand that from individuals with lived experience. So individuals with neurodevelopmental disorders and their loved ones, their supporters, their caregivers. And I will use those phrases interchangeably. I mostly use the word supporters now, but when I was doing this grant and writing this up, we used the word caregivers for some of the journals that we published in. And I welcome anyone's feedback, but I'll use those terms interchangeably: supporters, caregivers, loved ones, things like that. We know that people who support and get support from each other have lots of different titles. So the purpose of this qualitative study was to investigate what individuals with neurodevelopmental disorders and their caregivers valued, so that we could in the future go forward to define what is high quality care. But for now, when I wanted to start a new adult clinic, do other studies, I was like, we don't even know what to say is high quality without the input of people with lived experience. This purpose and every step of the way of this project, both qualitative and quantitative, was developed in consultation with our University Center of Excellence in Developmental Disabilities, UCED, in Colorado, which is called JFK Partners, with our Family Advisory Council. And that council is made up of individuals with autism spectrum disorder and other neurodevelopmental disorders. It's made up of supporters and caregivers. It's made up of clinicians and community leaders and community members. So it's a diverse group that provided me with fantastic direction and consultation throughout this project. We aim to uncover how adults with neurodevelopmental disorders and their caregivers experience interactions with the healthcare system in order to address their neurodevelopmental needs in adulthood. So our qualitative methods were semi-structured interviews with either an individual with a neurodevelopmental disorder, a dyad, meaning an individual plus their supporter or caregiver, or just the supporter or their caregiver. We developed an interview guide with input from the Patient and Family Advisory Council and presented iterations for review of what questions should we ask to really get at what people value. And that was very helpful to have that feedback. Also, I'll use images just to make things less boring that are from Access Gallery, which is a gallery that we've partnered with for other projects that employs and supports artists with neurodevelopmental disorders to make art and make money and employment from their art. So this is an example of a piece of art from Gabriel. So the interviews that we had were recorded, professionally transcribed verbatim, and then de-identified. And it's important to know that I personally, Dr. Sanders, did not participate in recruitment or data collection. And I was blinded to the identity of the participants because I was the neurodevelopmental physician for many of the adult patients, because unfortunately, there are not a plethora of adult neurodevelopmental disabilities doctors. If a participant had a legal guardian, then that legal guardian was contacted first based on research protocols, and then the analyst asked the guardian if the patient with neurodevelopmental disorders could consent or assent and participate in the interview. And that was always the goal, was to have full participation, no matter the guardianship status. The interviews continued until thematic saturation was reached, and that was at 22 interviews. The data was reviewed intermittently throughout the interview process, and interviews continued until the majority of concepts had been covered and repetitive themes emerged. So that was the thematic saturation. We used a content analysis type of qualitative method. And so what this entailed was codebook development, and then querying, and then theme development. And so there's a question of who is the target population for recruitment. So the target population for recruitment were adults with neurodevelopmental disorders. And the way we recruited them was to recruit, to ask patients to participate in interviews that were from clinics that saw adults with neurodevelopmental disorders in our university health system. So that's why I did not participate. I provided a list of my patients, and the research assistant randomly selected these patients to solicit for recruitment so that we could get a variety of perspectives that wasn't biased by my relationship with the patient. So even though I had likely seen many of them, um, I was not involved in selecting them. Please feel free to ask more questions or clarify in the future. Thank you. So to develop our code book, meaning how we were going to define what elements of interest we were going to pull from this huge data set of 22 interview transcripts that were each about an hour long, some went up to an hour and a half. Two members of the research team, me and our main qualitative analyst, independently reviewed transcripts to inductively identify a set of codes. So the codes were descriptors that captured the concepts and ideas that we discussed in the interviews. And inductively meant that we did not come in with a framework to start of what codes we wanted to have. We were really coming in fresh to the data to say, what are people valuing? What are individuals talking about, in order to guide us to the ultimate code book. The research team, so me and the analyst and another qualitative expert, met to review code lists and coded transcripts in order to reconcile discrepancies in code definitions and how we applied them to different transcripts. So we would each code through a whole transcript, the same one. We would come together and see how closely, identically we coded things in the same transcript. And we did that as an iterative process until a code book was established that we felt we were using similarly. So we applied the final codes to the remainder of all of the transcripts using a software called Atlas TI for qualitative data management. And we made sure that we double coded 20% of the transcripts, went over those together to make sure that there was synchrony in how we identified which codes fit which areas of the transcripts. Then, once we had coded all of the data, the codes were clustered into related categories to guide querying and theme development. So querying would be, we would pull a code such as communication or other codes, and then we would go through those queries together of different codes, but that would pull a single code from lots of different transcripts, from all of the different transcripts, to help us analyze what people were saying about that code from the 22 different perspectives. And that is how we guided our theme development. Now, our themes, we also used inductive analysis and ongoing discussion and lots of iterative reframing of the themes during weekly team meetings, as well as in between team meeting analysis. So that's the nitty-gritty of the methods. Anyone feel free to let me know if you have any questions or feedback on the methods part before we get into the more fun part to talk about, which is what we found. So here are the demographics of our study population. So 12 of the interviews included just a caregiver. 9 of them were a parent caregiver dyad, and in this population, only one patient, one individual participated by themselves. The caregiver sex was largely female. The relationship was mostly a parent, although there was a sibling and a child of someone and another caregiver, including a host home provider, and one was a legal guardian through a state agency. So the average age was about 30 years old. The range of participants, meaning the patient age, not the caregiver age, was 19 to 62. The patient sex was majority male, but there was a variety of distribution. And our racial and ethnic breakdown was majority white for this population. These are the diagnoses, and an individual participant could have multiple diagnoses from this list. So most patients had autism spectrum disorder, about half, so it's almost similar amount, also had intellectual disability. There was other genetic disorders, ADHD, Down syndrome, cerebral palsy. So the themes, our main results were, what did patients value? And I'm going to stop and look at a question real quick when we think about the themes. So was there a reason why it was majority caregiver only? were patients generally unavailable or could not participate. So that we can have a more in-depth analysis when we go through our quantitative data of who is seen in adult neurodevelopmental clinics at University of Colorado. But our clinics tend to involve individuals with with higher needs for supportive care. And so individuals who would not be able to verbally participate in an interview, although we encouraged participation with any form of communication, it was virtual, but including alternative augmented communication, gestures, other picture, things like that. And so we did get dyadic participation, but I think most patients were not able to participate completely on their own because our population includes autism spectrum disorder plus intellectual disability and very, very often communication disorder, which isn't reflected in our data. In future, we should collect that independently because it's not well reflected in the medical record, and we relied on the medical record for the diagnostic codes of these patients. But yes, communication disorder, I think, was a very large part of our population. So the overall themes from our interview participants, theme one was that they valued providers who are curious, engaged, knowledgeable about neurodevelopmental disability related conditions, which individuals and caregivers referred to often as unicorn providers. That was a term that was used a couple of times. They also valued a connected and coordinated web of care. And then there was value in a comfortable and adaptable clinical spaces. So we'll show you some of the descriptions and some representative quotes. So theme one was value in providers who are curious, engaged, and knowledgeable. And I'm just going to give a couple of quotes of each of these themes and sub-themes, but know that we have like just heaps and gobs of really deep data of what people thought. But these are some of the what I think are the most representative quotes from different participants. Well, he felt she was very engaged, and he is the individual, the patient. It's hard sometimes, but I feel like there was a connection there versus just going through the motions. I know my dad was a physician, so I understand how many patients you have. Each one can't be one and special all the time, but I felt she was engaged and concerned. Not concerned, but wanted to help with the patient's development. So the sub-theme of theme one was that they valued providers' comfort and flexibility in their approach to engaging directly with an individual with neurodevelopmental disorders. I say that's kind of the wishes and dreams of a special need parent, that you walk into a setting where it's clear that people understand and are not put off or turned off or frightened by what they might see. Just an air of acceptance, and whatever comes up, we can deal with this, and it's all good. We're all on a team and that kind of thing. I realized that I forgot to put a quote in here, one that always sticks with me about a patient being touched, that they talked about that very often doctors don't even touch their loved one with neurodevelopmental disabilities, and just to not be scared or put off, but to touch, to go through that physical exam was a value. Another sub-theme of this first main theme of engaged, knowledgeable providers is that they're curious and experienced enough to view the whole patient, not just the individual neurodevelopmental concerns or medical concerns. We find people that will work with autism, for example, or that will work with brain injury. For him, if you use only interventions that would work for autism, it's incomplete. If you use only the brain injury component, it's incomplete. So they have to mesh. So patients and caregivers realizing that there are lots of comorbidities that intersect with neurodevelopmental disorders that need to be addressed holistically. They also value when a provider actually listens, is actually trying to find solutions. It's not just a waste of time trying to figure things out that can help. Theme two is value in a connected and coordinated web of care. And this is very complicated. As you all know, our systems are really difficult to navigate for anyone, let alone for children with disabilities, and then let alone for adults with neurodevelopmental disorders. Yeah, I see now. That's what I'm liking about this. It's like it's good to have this specialist here in this area and this specialist in that area, and we've got a team approach. So this patient was reflecting on their neurodevelopmental specialist being like a quarterback, knowing the different specialists in the different areas and being able to incorporate those into a team approach. Another one wrote, she's very knowledgeable. I know if she's not able to assist with whatever we need, she'll point us in the right direction. Again, that the physician or the clinic is connected and not just standalone, identifying the autism or whatever other neurodevelopmental need, but being able to connect them with other things that will help with whatever other comorbidities they experience. Sub-theme 2A was facilitating connections to customized care. So this is not just connecting with everyone, but knowing the right person to connect with. Like, will this sleep specialist really evaluate their sleep for what it is? Or will they just say, oh, they just have autism and sleep problems come with autism, so we're done? So some quotes about this that caregivers and individuals had was, people with special needs tend to kind of get passed around the medical community. And that family just really wanted customized care, not just getting passed to the next person, but someone really taking an interest and connecting them with what they needed. None of them you could follow. So this was about being able to have longitudinal care, and they didn't keep any of them. It literally was, I was for the most part, take her to an urgent care if she seemed sick. It was easier. I could get right in. I didn't see the same people at the clinic anyway, most of the time. That's hard for primary care and neurology, I think, to be constantly going in, reintroducing ourselves to a new doctor is exhausting. And it's really not helpful. Nobody follows her, if you understand what I'm saying. So they really wanted doctors and providers that could have long-term connections to the individual and to their teams. So sub-theme 2B was navigating and integrating care. I think it's really important that the providers and the team not only be willing, but also know the importance of speaking with the other providers on the patient's team. That's something, generally speaking, I've struggled with other folks that don't already have this well-greased machine going within their provider network of trying to get folks to speak with one another. I think that someone that has a neurodevelopmental diagnosis, that's probably not the only thing going on. And at least in my experience, it's a combination with a couple other things, and that makes it more complex. That communication is extremely important. Another quote, someone that can help him navigate through life as far as with these differences. What other help does he need? Where can he find it? What has worked for other similar clients? Resources are huge. Finding, being directed to someone that they know, as opposed to just being given a list of possibilities to call. Having a very definite, this person can help is huge. So these kinds of quotes inspired me to connect with other programs to start having more intensive case management and guidance in our adult neurodevelopmental clinic outside of just the medical needs like prescriptions and medications and medical equipment. And so we now have a new grant. So thanks to AARP allowing us to have this pilot data, we were able to get a new grant that has allowed us to do intensive case management with vocational and benefits planning. And it's really because of a lot of this work where we were able to show the need and what individuals and their supporters value is having someone that can follow them more than just a doctor to make sure they're really connected to these things. So now we have intensive case management as an option in my clinic, thanks to this work. So theme 3, a lot harder to change, but we will get there, is value in comfortable and adaptable clinic spaces. So one family said crowds tend to make her a little crazy too, which is what we always ran into at the other clinic we went to. We went back pretty quickly. The nurse came in and talked to us for a second. Then doctor and a person came in. It was so nice, I can't even tell you. So they really liked not having to sit in the waiting room, not having to be in a crowd. Another quote was saying, it was really interesting. Even at the very first appointment, we sat in an office and the patient was having sensory movements and was having a really hard time engaging with her. And it was a really nice day outside. And she said, I didn't even have to say anything. She said, hey, would you rather sit outside in the sun? Would that be nicer? And he's like, yes. So they go and he follows her out the door and they sat at a picnic bench and he opened up and started talking to her. I just sat at the end of the table. So this was about a provider being flexible to take the patient outside, think outside the box, that the clinic room isn't necessarily always the place where you have to stay to get information, or at least to build a relationship in adult neurodevelopmental care to get that patient who might be new to you to, to develop trust in that therapeutic alliance. So a sub-theme of this was having easy access to the clinic, which is definitely a challenge. But people felt that, here's a quote, "It's a bit further. It's one of those things collectively as a team. It's more important for us to have the right person than for it to be the closest person." And this individual also talked about how, yes, it was worth the drive, but they also really liked the setting where you don't have to go through, this specific clinic, you don't have to go into a main hospital. They liked it that it was a smaller setting that they could feel more comfortable in, not as many crowds, things like that. Another family said, "I feel like when you go to a doctor, especially specialists, and you go time and time again and you explain your history, at some point it sinks in that I'm not like anyone else." I feel like when you feel that way and you actually walk into a doctor's office, you expect everybody to turn around and look at you as if you're not like everyone else. When you just want to be like everyone else. When you're in a virtual visit, you don't have to worry about that. I feel like that removes a lot of the limitations of going in and seeing your doctor, because I think going into it, your mindset is just different. So a lot of the patients and families, it was interesting in this data set, it was very split of they loved the in-person option of getting to know someone, being flexible, take them down the hall, take them outside, all of these values of sensory experiences in the clinic. But then they also really valued the option of having telehealth when it was appropriate. So some said, "I don't ever want to do telehealth. They can't know my loved one with telehealth." And others say, telehealth is wonderful. So this has helped shape our adult neurodevelopmental clinic to continue to offer telehealth and in person, and we can always change and make decisions for future visits based on what the individual needs medically and therapeutically. So the last sub-theme was the experience of the physical setting and clinical space, which I sort of jumped to and alluded to already. But ultimately, a lot of the families in our data set were worried and intimidated about going to adult clinical spaces because of their loved ones' emotional or behavioral triggers that could lead to challenging behaviors, and them feeling like the adult space is not equipped for that. So them just being fearful of transitioning to the adult healthcare system. So they ultimately, when we pressed them more in the interviews, they wanted fewer providers in the room. They wanted sensory-friendly spaces as close as possible to pediatric spaces that downplay the medicalization, like if possible, talking in a room without an exam table, things like that. And then flexible appointment settings, short wait times, or at least private places to wait. I know that providing sensory-friendly spaces is a big deal right now. You think that we're coming from, Children's Hospital, so how bright and lively and fun, so to speak, that hospital or place was. She always knew that we were going to that neurologist, the same, the same, the same. Then when she turns into an adult, it all just turns to static because you're going to the adult space, but you can still have somebody who's 18 months old who liked the bright, fun colors or the availability of maybe not age appropriate toys, but that would make her feel more comfortable in a space. So this is to realize that we can bring in things that might not be adult age appropriate to help people feel comfortable, or encourage them to bring things that would make them feel comfortable in adult spaces, which we have a long way to go, but we are working on that. Any other questions about the qualitative data and themes that we got? I think I'll read out one while anyone wants to write others. How do you account for the potential variability in responses in the dyad interviews between the patients and their caregivers? So for this project, we were not powered to have subgroup analyses, but I would hope in the future, um, with larger grant and projects, to be able to have more purposeful sampling so that we could compare and do subgroup analyses between people who participated with the individual, and comparing that to responses of without the individual patient. I'm just the caregiver. But this did not have enough power to analyze that. So we really just analyzed the dyad as a unit of all of the different things they said, coded the data of the whole transcript just the same, and compared and just integrated those codes. We did not compare them in subgroup analysis for this project. But I would love to, or if you want to do that with me, let's do it. That'd be great. Any other questions about the qualitative data or methods or anything like that before we go through some of the quantitative data? So with this AARP support, we were able to do the interviews that we just described, and then also a chart review of the first year of starting an adult neurodevelopmental disabilities clinic in an adult hospital setting. So we're located at University of Colorado. We have the Children's Hospital of Colorado, which is its own hospital healthcare system. And then we have the University of Colorado healthcare system, UC Health, which is the adult system. And they are connected on the same campus and academically connected, where the physicians are all professors, assistant professors, faculty, all at the same medical school, the University of Colorado. But the actual hospitals are not directly connected. Completely different electronic medical records, nurses, referral systems, all of that. So the goal was to start a neurodevelopmental clinic specifically in the adult hospital system to help facilitate transition to adulthood. Yeah, that's a good question. Were the dyads in agreement with each other, or did you get different responses from the patient and caregiver? So that was not something also that we particularly analyzed, but I would love to analyze that in the future. And I think that's a big limitation of our study, that we didn't specifically pull out data from the dyad of what individual was speaking. It was really taken as a unit where we coded the whole transcript as one. But interestingly, so we have a big university center here for qualitative and mixed methods research. And ever since doing this project, this center has now taken on, they are, experts in PhDs in qualitative methodology. And so they are now doing a lot of methodologic work on how to do better dyadic interviews, because that is something that there's not as much in the literature as there are on semi-structured individual interviews. So that is cool that we've now inspired this whole center at the University of Colorado to do more methodologic investigation on best practices for getting the opinions when there are two people in a semi-structured interview. Whereas we have those methods for focus groups of getting different points of view, things like that. But it's a little bit different when it's a semi-structured interview. So stay tuned. I think that's a cool body of work coming out that's not from me, but because of this particular project, it was inspired other people to do that. Others I'm missing. So this was another paper that came out of this project. So describing the first year of starting an adult neurodevelopmental disabilities clinic. So there's a lot of nitty gritty in there, but I just wanted to at least show you the demographics so you can see who we saw in this first year of an adult neurodevelopmental clinic. So the age at first office clinic, the most common age was in the 20s, but we saw people ranging from 18 years old all the way up to someone in their 80s. And then in terms of the genders, it was about 70% male, 29% female. Gender identity also reflected that similar distribution. The race, again, this reflects a little bit more of the makeup of the state of Colorado, but not at all enough. There's a lot more Hispanic, Latino in the state of Colorado than reflected in this population, but this is a little bit closer. So we hope future studies that we can continue to have our population represent the state of Colorado. Mostly people from urban zip codes came to our clinic, but we did have several people from far away rural places in Colorado. And this is just in the first year. So we've developed more telehealth capacity and things like that to serve more rural individuals since this data has been published. Majority of individuals lived with a parent or family member, but several lived independently or with a host home or group home or supported independent living environments. Their primary caretakers, if they had one, was mostly another family member, but also group or host home as well. And then for guardianship, about half of our patients had a legal guardian, and then a little less than half were their own guardian. And we worked on talking to families and individuals about options for power of attorney, healthcare proxy, and all of those things. And that's reflected in our data as well. Insurance type, so about half had Medicaid. And then in terms of basically comparing private versus public, much more than half had public paid insurance compared to private insurance in our adult population of adult neurodevelopmental disorders. And we also collected BMI. We worked on collecting other outcomes as well to just sort of define what's in our population. So in terms of their developmental diagnoses, so over half had intellectual disability and just about half had autism spectrum disorder. There were also other genetic diagnoses, ADHD, Down syndrome, and other developmental diagnoses such as apraxia, fetal alcohol syndrome, cerebral palsy. And then we collected, based on billing data, of a lot of the different comorbidities that can come with these neurodevelopmental disorders, such as behavioral concerns, anxiety, abnormal movements, seizure disorders, sleep disorders, cognitive decline, depression, abnormal imaging results people come with, feeding difficulties, hearing vision impairment, catatonia, chronic pain fatigue, and functional neurologic disorders, also previously called psychogenic non-epileptic spells. And so we talked about these comorbidities as well as BMI and other things to show that this adult population is not so dissimilar from other adult neurology populations. And so where we published this article was in Cognitive Behavioral Neurology to demonstrate that an adult neurodevelopmental clinic, we're bringing in patients with their primary diagnosis being autism spectrum disorder or intellectual disability or Down syndrome or other things, but the comorbidities that they come with are really similarly mapped to comorbidities of other adult neurology clinics, such as neuroimmunology, like multiple sclerosis, or such as stroke, where there are seizures that confound, there are behavioral and mental health concerns. And so we really wanted to show that other neurology departments can do adult neurodevelopmental care because they have the support for taking care of these comorbidities. We just need to be open to adapting these supportive programs for people with neurodiversity. And that is the main key. So taking that qualitative data of these values that we have, putting that together with our quantitative data of what are the comorbidities and medical problems and neurologic needs that people have in adulthood when they have a primary neurodevelopmental disability, and how can we care for them without expecting a developmental pediatrician to see patients that are 60 years old at a university or adult hospital. So adults with neurodevelopmental disorders and their caregivers value access to providers who can engage with individuals with neurodevelopmental disorders, meaning touch them, talk to them, be flexible about how you interact with them, offer new diagnoses and approaches, being curious about them, keeping individuals and families' priorities in mind, along with the entire healthcare big picture when guiding care. So keeping that network in mind, what else do people need to achieve maximum health in addition to what's in your paradigm of whatever clinic you are in as an adult provider. This population longs for support in coordinating care across health and community agencies and values clinics that can adapt their spaces to make things comfortable and successful for neurodiverse patients. So next steps in my mind from these projects are to improve outcome measures. So now how can we show that a clinic is providing high quality neurodevelopmental care? We now have this qualitative data and a little bit of quantitative data to show what the population entails and what they want. So we need to move forward with agencies and policymakers of what are outcomes that we should be measuring for adult neurodevelopmental care to show that clinics are providing high quality care. We also need to augment training programs to prepare adult providers to provide adult neurodevelopmental care. So this is something that I work on. I was talking about that partnership with Access Gallery of bringing artists to adult residencies such as psychiatry, neurology, internal medicine, surgery, and giving these residents experiences with artists in the community that have neurodevelopmental disorders to just have experience communicating with that population. So that's one intervention that I'm working on from this data set. And then I know lots of people are working on many, many others to train adult providers to be able to care for the neurodevelopmental or neurodiverse patient who has comorbidities or medical problems just like a lot of their other patients. And a lot of the comorbidities and medical problems can be unique, but that's where specialists can be brought in. So the training needs are huge, lots of people working on it. I know lots of people on this call, I'm sure, are too. And then the ultimate next steps are designing clinics to align with what individuals with neurodevelopmental disorders and their caregivers value. So bringing in that flexibility that we often have in a pediatric space that is not the standard of care in an adult space, bringing in those supportive measures like sensory options and facilitating successful procedures and things on the adult side, just like we have support to do in a lot of pediatric healthcare systems. And then also helping staff and physicians feel like they are empowered to care for these patients in ways that can be flexible, that they might not always feel empowered to do. Like, for example, our adult neurodevelopmental clinic, we've gotten labs or done vaccines for people in the car. So I have a lot of mixed feelings about how should we push this forward with designing clinics? I think that every clinic should be able to take care of the whole rainbow of neurodiversity and neurodiverse patients. However, I have seen now the benefit of starting with an isolated adult neurodevelopmental clinic so that other doctors can see, oh, this is what we do here, rather than in the adult healthcare system, rather than having a one-off patient one time in a primary care clinic over here or a neurology clinic over there, saying, okay, there is a neurodevelopmental clinic that's in this adult healthcare system. So they're going to need these tests and these specialists. And now I know we can do that because there's that adult doctor doing that adult neurodevelopmental clinic who we can consult. So I see it both ways. This data did not push me one way or another to sort of segregation versus integration. And I think the dream would be to have both options where all clinics are accessible and available to adults with neurodevelopmental disorders, but there are specialty places where really can be a resource not only to patients, but to physicians and other staff of how to give the best possible care to that population. This is my information. I'm going to look in now the chat of what other questions there are, but please feel free to ask more. Happy to have people unmute as well. So what tangible recommendations do you have for adult NDD care coordination based on these data? So the project that we are doing ongoing now is having monthly intensive case management visits with someone who's trained as a vocational counselor and a benefits counselor, because realizing that people accessing benefits, the right benefits that they are eligible for, is such a huge part of quality of life, of meaning getting on the correct Medicaid waivers, knowing that that waiver can cover certain things like vocational supports or respite care or exercise assistance, all of the things that make for a healthy, high quality life. And so those are the tangible recommendations I have, is someone who is knowledgeable in benefits counseling to get individuals the benefits they deserve that can then get them the services they deserve, because the benefits pay for the services. Are the non-neurologic healthcare needs being addressed at this NDD clinic? Really great question. So we now have a vocation counselor who is coming to our clinic. So that's one of, I mean, I guess you could call that a neurologic or non-neurologic need, but the benefits and vocation counselor is now part of our clinic. We also have a genetic counselor, And we have an embedded health psychologist. So she can meet with the individual with short notice, and then she can provide, if it's ongoing therapy with her, that's a possibility, but very often it's providing, our patients can live all over Colorado. So providing resources and navigation to mental health care that is in the community that would meet the individual's needs mostly. So that is a really cool advancement in our clinic. That's not just for adult neurodevelopmental care. I'm in an adult behavioral neurology clinic that mostly serves patients with dementia, and I get to benefit from their services as well. Um, the art, yes. So we pay the Access Gallery artists their rate, which currently is $20 an hour, but whatever their salary is that they request, we pay. And we started out with a grant from the Colorado Developmental Disabilities Council to bring the artists to residency programs, and now hope to keep it sustainable by having the residency programs love it and ask for it back. So we're hoping in future years that residency programs will pick up the bill and pay the artists for their time. We pay for their time, we pay for their transportation, and for any material costs incurred. So we did have a grant for the last 2 years that paid for that. And now we hope to keep it sustainable by having buy-in from the residency programs themselves. So stay tuned. And then do we have a dedicated set of social workers to help with housing, different resources for managing life in the community transition that comes with adulthood? So being completely honest, in a neurology clinic, it's neurology social workers. And so they are very open to training on the job, but I don't have, like, I work in developmental pediatrics and neurology. Um, and so in this adult clinic, it is the neurology social workers, but they can call across to the children's hospital and ask specific questions of the developmental pediatrics social workers, which has happened a couple times, which has been really helpful. And so they are sort of constantly training on how to serve adults with neurodevelopmental disorders because they're used to strokes and dementia, but some of the times those things aren't so dissimilar. And then what about addressing general health needs that a PCP would take care of? So we partner with the primary care, the general internal medicine and family medicine clinics at University of Colorado for providing primary care. And it's truly a dream getting to work here. The medical director of the general internal medicine clinic, her training is in med peds and her passion is adults with complex medical problems. And so she, like me, sees adult patients at the Children's Hospital in what's called the Special Care Clinic and in general internal medicine, where she's the medical director of the whole clinic. So we really have the eyes and ears of the internal medicine team at University of Colorado because of that connection, to have not only that physician be able to see patients with neurodevelopmental disorders, but to have that be a population that is a priority to make sure is accessible. So it's nowhere near perfect. We have a long ways to go, but at least we have really willing colleagues in primary care. So I don't practice primary care for my patients. I do their neurology and neurodevelopmental care and partner with primary care. But that partnership has been incredible. So I'll see patients for, cognitive decline, or they're slowing down, not walking as fast as they were, and do a whole workup. One time I got a history that the patient had weight loss and just some odd symptoms. And I added a TB test to my list of labs and it was positive. So then partnered with primary care colleagues to get that treated quickly. And just because that individual had a neurodevelopmental disorder didn't mean they didn't also have tuberculosis. So there's always examples of things like that where we partner together. And we have similar things the other way around. One of my colleagues had an adult patient who had autism spectrum disorder and was just such a picky eater that she was incredibly anemic. Her hemoglobin came in, it was like 5 or 4 or something, like she needed transfusions. It was very severe. And so then she was able to partner with me on getting this patient officially a diagnosis of autism and getting services to help them even as an adult. So we have a lot of great partnership with primary care here, which is awesome. And how do patients get referred? They can call themselves, they can see any neurologist in UC Health or in the community that can refer, or their primary care. it's really open to anyone. And we see any insurance, all things like that, um, for my personal neurodevelopmental practice. And then same thing with our primary care colleagues. And what would be the different in terms of the environment set for those specialty clinics than from enhanced primary care doctors? If you want to, I don't know, Ben, are we able to unmute people to like clarify that?
In this webinar, there is no unmute option, but if you
Okay.
would like to paste to reframe the question in the chat, please do so. Use this opportunity to talk to Dr. Sanders.
Yeah. Let me, what, can you put that one in the chat? I lost it.
Sure,
Just
1 second.
setting. Thank you. And so this is meant to cover all types of healthcare, like physical, psychology, psychiatry. So as a neurodevelopmental pediatrician, neurodevelopmental disabilities doctor, we do go through everything because that's what we're used to doing. But technically, we are not their primary care. So we make sure that they have primary care and we make sure if they need a psychiatrist, that they have a psychiatrist. I do and can manage medications just as much as any other neurologist can for comorbidities of anxiety, depression, things like that. And then I get patients that have catatonia, agitated catatonia, and I'll get started on things. And then I partner with psychiatrists as well. So we have community psychiatrists that are really great to partner with, honestly, outside of the academic system. And then we do have some, like I have two colleagues that are double board certified in neurology and psychiatry that I work closely with because I know them through neurology that can help with that. Yeah, so it's like there's only so many specialty clinics that we can have. Um, but sometimes we identify that there's a need for lots of doctors to get together. So another thing that, and I realize we're out of time, I want to respect everyone's time, but I guess one take home point too that has really helped me be successful is networking socially with other doctors and providers and individuals. So about 3.5 years ago, we started having dinner together. So that doctor that I mentioned, the director, the medical director of the internal medicine clinic, she's trained in med peds, really passionate about complex care. So her and I started networking to gather a group of people where we now have dinner once a month without fail, going on, 4 years pretty soon. And so that's been pretty awesome. The group consists of an ophthalmologist. So he's a pediatric ophthalmologist who sees adults with neurodevelopmental disorders on the adult campus. It's all people that are trained in pediatrics that see also adults on the adult campus for their specialty. We have a urologist, we have a social worker who comes. So that's a UC Health social worker, adult, who's been a great asset. And we have primary care, we have endocrinology, we have nephrology. So we're constantly growing that dinner group, but it's just been an informal grassroots of get people together so you can start clinics and know who to refer to and build it. Because I think what I found is there's really no other way besides word of mouth and asking for help and knowing who to call in your adult healthcare systems to take care of adults with disabilities.
Amazing. Thank you so much, Dr. Sanders. Loved all the questions and the interaction. I posted in the chat for those who are still here a couple different links. I'll just go through them briefly. We have the archive. If you would like to watch this webinar again, you can do so at the link above. There's also a post-webinar survey, as I mentioned at the beginning, that would love for you all to take to give feedback to ARP for future webinars, so we can provide the topics that you want to hear. If you have questions, you can email me at bnegron@mednet.ucla.edu. And then our next webinar is November 19th, same time. It's featuring Dr. Kelly Beck, who is a professor for the Clinical Mental Health Counseling Program at the University of Pittsburgh. And then, as I mentioned, the research day at AAC 2024 for ARP. I put a link there as well. But thank you so much all for coming. I hope to see you at the next one. And thank you, Dr. Sanders.
Thank you so much.